nice way to end November. So today I'm going to talk a bit about some work that I've been doing throughout my dissertation on improving veteran access to care for chronic eye disease. And this is a sort of a practice run of talks that I'll be giving for job interviews for faculty positions. So I was telling Renata earlier, there will be a lot of folks who will probably be interrupting me throughout those talks. So please feel free to interrupt throughout my talk. I'm happy to answer questions at any time and also save some time at the end for questions too. So a bit of background kind of on my academic and professional journey, because it really informs the sort of research that I conduct. So I started here in Ann Arbor, getting my bachelor's in industrial and operations engineering. And I was really interested in how we could apply a lot of these quantitative tools to public health problems. And so I went on and got my master's in public health at Yale and focused in chronic disease epidemiology. During my MPH, a lot of the work was on decision analysis in more global health contexts, including performing cost effectiveness analyses for HIV therapies for pregnant women in sub-Saharan Africa. And after I finished my MPH, I wanted to learn a little bit more about the US healthcare system, since I'd been focusing so much time in global health. And also between industrial engineering and studying epidemiology, I was sitting behind a computer crunching numbers a whole lot, which I love to do, but also wanted to understand really kind of what does it look like from a higher up position within a healthcare system. So I began working at the Health Management Academy in Washington, DC, where I worked with chief medical officers and oncology executives at integrated health systems throughout the US. And also started a leadership program for physicians who were starting to rise through the ranks within their careers. Following my time at the academy, I worked as a health systems engineer at Mayo Clinic for a couple of years. And I found the kind of work applying a lot of the engineering tools to direct patient problems to actually get solutions going on the ground to be really rewarding. But I had a really strong itch to teach more within my professional career, and so decided to come back to Michigan and finish my, or begin and hopefully soon finish my PhD in industrial and operations engineering, the research of which I'll talk about today. And we'll see what's next. So jumping into my research broadly, my overall goal is to look at how we can develop industrial and engineering tools to guide policy decisions that help to improve healthcare access for veterans. And kind of the objectives within this goal are to connect veterans to the most appropriate healthcare resources so that both they have the best possible outcomes clinically, and also we can see the best possible outcomes from a system perspective, from the VA. I also really want to be able to highlight the trade-offs that are inherent within policy decisions. So noting that it's not just kind of solving some mathematical models to get the best objective value or find the minimum cost. There's really a lot of trade-offs as we're starting to think about kind of what are the ways we can think about policies. So thinking about access to healthcare broadly, about a third of Americans report an unmet health need or some sort of delay in seeking healthcare, and that's kind of throughout all of Americans, not just veterans. And these delays or unmet needs can lead to several less than great outcomes, negative health outcomes, kind of clinical outcomes for the patient, increased costs both for the patient as well as for the system. And then operational burden, largely burden on the system as they're trying to figure out how to handle patients who maybe had these delays in seeking care. There's also operational burden on patients as they sort of try to figure out how to navigate a system that they're already having trouble accessing. And you think there would be a lot of sort of straightforward solutions to kind of create a broad health system throughout the US that really meets all of the needs of patients. And so there's this quote here from a Day and Anderson paper that there's a variety of competing proposals before Congress to provide a more universal health insurance coverage to the population which is even just one small aspect of healthcare access. And this quote is from a paper that was in 1974. And as I'm sure we've all noticed, we don't have quite a universal health insurance coverage program yet within the US. So a lot of issues with access that have been going on for a long time and are still continuing to create important problems for us to solve. And access isn't just located within one chunk of the US, it's really widespread throughout the country. So the green, red, and yellow areas here indicate medically underserved areas, which are all the green counties. And then the red and yellow counties are medically underserved populations. And those mean that maybe not the entire county is not medically underserved, but some subset of the population is underserved. And these are based on different criteria, including the ratio of the population to the number of providers, the percent of the population below the federal poverty level, the percent of the population who's older, over 65, and then the infant mortality rate. So I'm going to talk today a little bit about access to eye care for veterans. And so let's think about kind of focusing in on from broadly what's going on with access to, with healthcare access throughout the country to access to eye care among veterans. Access is a really big challenge, especially for veterans who live in rural areas. And this is really important because people who live in rural areas tend to be older and tend to be a lower socioeconomic status than those living in urban areas. So the barriers to access kind of build and build. Among veterans, they report greater delays in seeking healthcare than non-veterans. And then specifically thinking about eye care is the third most utilized service within the VA after primary care and mental health services. So access to eye care is really important. Additionally, diabetes prevalence among VA patients is about 4% higher than in the general US population. And this is really important because diabetes is a strong indicator for many eye diseases, including diabetic retinopathy. So the work that we conduct, even though we have all these problems with access, we can perform some really important work. And that's also thanks to the VA's, the way that the VA is structured. So first, the VA is cost incentivized to reduce access barriers. Because of the structure of the VA, patients typically stay within the system, and ideally we'd like them to stay in the system as much as possible. And because of that, providers are cost incentivized to kind of get patients the right care at the right time, as well as to prevent diseases from progressing into more negative outcomes. Additionally, because of that, patients' utilization is relatively consistent. Most patients, once they start going to the VA, they'll stay going unless something happens where their care is disrupted. There's also strong care coordination across the VA, and specifically for the purposes of our work, care coordination between primary care and ophthalmology or eye care is really important. So our work is looking at veteran eye care specifically in Georgia. So let's kind of think about what life would be like for a veteran living in Georgia. So let's say you are a vet living down here in the kind of the southeast corner of Georgia, which is right around Savannah. And there's a handful of eye care clinics throughout the VA where you might be able to get care. But none of those those clinics that offer eye care is particularly close to you. And because of that, you're either going to have to drive a really long distance to get to care. And this could be dangerous for patients, especially if they're having eye problems. We want to make sure that they're safe to be on the road. But also, you may just go seek care outside of the VA from a community provider. We also don't want that because we would like care to stay within the VA as much as possible so that that coordination can stay. So within our research, we partner with folks at the VA who developed a program that looks at the adding eye care services to primary care clinics, to clinics that offer primary care throughout the VA. And there are more clinics that offer primary care throughout the system. So there are a lot more opportunities to get eye care. So if you're that patient who lives down in that southeast corner around Savannah, you might have a primary care location right nearby. It's a lot easier to get to. So this program combines patients who are coming in for a primary care visit. There is a trained technician who's going to perform an eye screening during that primary care visit with the patient. And what we're really trying to find out is how do we kind of set up this system throughout the VA system within Georgia to understand kind of what are the operational and financial outcomes for the VA, as well as how do we make sure that patient outcomes are either at least maintained and at best improved when using a system like this. So this system where we combine a primary care visit with a technician performing a screening was developed by Dr. April Ma, one of our collaborators, and it's called the TECS program, or Technology-Based Eye Care Services. And so we have an ophthalmic technician who works full-time at a primary care clinic. And when patients come in, they perform a detailed patient history. They take clinical readings like eye pressure, as well as photos of the eye. And they also measure a patient's vision and can prescribe eyeglasses. That last bit is really important. Those eyeglasses are huge motivators for vets to come in and get their eyes screened. When they were developing the program, it was sort of a small bonus that they were hoping would be helpful, and it's turned out to be kind of a really big draw for vets to come in and use this program. So the technicians take all of those measurements, they upload it into a record within the VA's online medical system, and then submit that to an ophthalmologist who interprets the results remotely and sends information or any diagnoses back to the patient. And specifically, these patients are screened for 4 major eye diseases, chronic eye diseases, including cataract, glaucoma, diabetic retinopathy, and macular degeneration. So these ophthalmologists who are doing the remote interpretation, they're ophthalmologists who are already working in the VA and kind of will shift one of their days of work to be kind of a day or a half day spent reviewing TECS records. So how do we form this into an operations research or an industrial engineering problem? So we are helping the VA decide how to evaluate at which locations within the Georgia VA they should be offering eye care screenings, what provider types should staff each clinic location, and which locations patients should visit among those potential clinic locations. We assume that patients go to an assigned clinic for their eye care screening. We model this over a 1-year time frame, and with that, patients also have a homogeneous screening need where they basically need 1 chronic eye disease screening every other year. We have a few limitations in how we model this, including right now or in the model I'm going to present first, we really consider eye screening only. We don't include any follow-up care if a patient does have any significant eye disease. And we also don't have any consideration for patients' provider preferences. So if a patient really would like to be seen by an ophthalmologist and our model says, no, we'd like you to see a technician for your screening because that's going to work best for the overall system, there isn't a ton of consideration for those patient preferences. However, I'll also talk about a constraint that we add that will start to take into account patients' preferences and kind of patients' needs. So our general approach here is we have 28 possible locations in Georgia. So there's 28 existing clinics, some of which offer eye care right now and some of which don't. But all of them are candidate clinic locations where we might offer eye care within our model. We decide at which locations we're going to offer eye care, what kinds of providers should staff each location, and then take patients from a given zip code and assign them to clinic locations. So the data that we use for this model is all from the VA. So we have patients who access the Georgia VA for any type of care in 2017 as our patient population. This is about 200,000 patients who are grouped by zip code. We have our 28 possible clinic locations in Georgia. 15 of these currently offer some type of eye care, and 6 of them currently offer TECS. So TECS has kind of started within a pilot version just to make sure that the program itself worked from a clinical perspective. But we are really making, with our models, we're really helping to decide what are the best locations to put those technicians or other eye care providers to improve access to eye screening. We calculate driving distances from the center of each zip code to each clinic location, and it's calculated via Google API. The zip codes throughout Georgia, Georgia actually has quite a few zip codes, I think more than the average state per square area. So the center of each zip code is a pretty good proxy for patients who are traveling to each of the different clinic locations. We have information about the budget and costs, the provider capacities, and other clinic values that we get from the VA. And then we formulate this as a mixed integer program that we implement into C++. All right, so let's get a little bit into the model. So we have 2 main decision variables. We have W, which is the number of patients from a given zip code Z that visit provider of type T at clinic C. And then we have Y, which is the number of providers of type T at clinic C. We have a handful of feasibility constraints. First one on patient capacity to make sure that we are not seeing any more patients than we have the capacity to see at each location. We also have a lower bound on the number of patients we need to see so that we're not putting a technician out in the middle of a rural area in Georgia and then they see 2 patients. So usually we keep this at around 80% of capacity needs to be used. We have provider capacity. So first, for each type of provider, a clinic can only handle so many of that type. So you might say, we don't want to have more than 4 ophthalmologists at this clinic, or we might not want to have more than 10 technicians. And then also, due to space, the clinic can also only handle so many of all types of eye care providers. We have constraints on the furthest distance or time that patients can travel to get to care. And these are values that are provided by the VA, and they're restrictions that are related to more administrative rules. And so if patients live further than that distance from a candidate clinic, they can't be assigned to that clinic. We also have constraints on demand. And with these, we have a certain percentage that patients need to be seen from each zip code. So if a clinic is within range of a zip code, we need to see at least 10% of patients from that zip code. And that really helps to make sure that there's equity in our model, that we're not just seeing all of the patients right around Atlanta, we're really spreading out the care that's getting provided. We also have an upper limit on the number of patients that we can see. Because patients are screened every other year, we only want to see half of the patients, or 50% within our model. And then we use 2 objective functions to understand this model and kind of figure out what are the trade-offs for each of them. So first is maximizing the number of patients that we assign, which is just maximizing W. And then we also, within that model, add a constraint around the budget. And the second objective function is minimizing our overall cost, plus including a constraint about the minimum number of patients that we need to see. So for the industrial engineering folks, you might say, well, you could just formulate this as a multi-criteria objective function. And we could do that. We have kind of formulated that out, but we do keep them as 2 separate models just because this first one of maximizing patients assigned is really more what's going to be useful to the VA. And the second model is just for comparison, so we can say, what does it look like when we are trying to minimize overall costs instead of just trying to maximize the number of patients that we screen. Some of our baseline model inputs here, we include a budget of $25 million for the entire system. We have a driving reimbursement for patients, and so we want to make sure we consider that as well. If patients are sent out of the VA to get screened, then we incur a penalty cost of $250. The VA covers the cost of care for patients who are not able to get the care that they need within the VA, and so that penalty cost sort of represents that value. Our clinic capacity is typically 3 providers overall. There's a handful of clinics that have more space than that, but generally for most of the clinics, it's 3%. Providers need to use at least 80% of their capacity. Patients can't drive any further than 40 miles or 60 minutes. And then we see between 10 and 50% of patients from each zip code. And then we have 3 types of providers that could staff our clinics: ophthalmologists, optometrists, and technicians. And each of them have associated kind of baseline costs to hire them, as well as the equipment that would be needed to outfit a clinical room and their salary. And then we have associated screening visit costs that are incurred every time a screening visit happens. And then they have affiliated capacity as well. Any questions about the kind of structure and inputs of the model before I get into some of the results?
Yeah, I have a couple questions if you don't mind.
Sure thing.
So you've got data from the VA here, right?
Yeah.
So do you have data on if they go, so I assume they go outside of the VA because of that that new Mission Act rule, right?
Yeah.
Where they have to be within an hour driving distance of a particular clinic within a certain amount of, they get an appointment a certain amount of time, right?
Yeah.
Do you have data on like how many patients leak that way?
We don't for this population, and some of the other work that I'm going to touch on just briefly at the end, we are starting to get some more information about that, actually largely more COVID related, of patients who have started to seek care elsewhere because of capacity restrictions put in place by COVID. But we don't have it for this specific population. We just have the patients who kind of used the VA for any care during 2017.
Okay, and do you have information on enrollees or just people who used care?
Just the people who have used care.
Okay.
Yeah.
All right. Cool. Thank you.
Yep. Any other questions?
Oh, I had one more question.
Hmm.
So are you looking only at existing facilities, or are you looking at potentially opening up new facilities?
So we're looking at existing VA facilities, some of which currently have eye care and some of which don't. We are not looking at kind of where we could place other clinics if we put it in one spot, this would improve care in such way. It's just places that could potentially house eye care, as well as that primary care that's affiliated with the technician visit.
Okay, so it's like capacity allocation instead of capacity creation.
Yeah, exactly.
Okay. Great, thank you.
Yep. No problem.
So I too have a question.
Sure
Percent of zip code to screen.
Mm-hmm.
How are you establishing that demand?
So we want to make sure that the eye screenings are available to all the patients who should be getting them in a given year, which is 50%, if we're saying patients need to be screened every other year. And then that 10% is there to make sure that we're not ignoring a zip code, especially those that are further away from the clinic, to make sure that there's at least 10% of patients allocated to care.
Got it. So the 50% is based on prescriptively everybody should see their eye doctor every other year. Is that?
Yeah.
Got
yes,
it. Thank
exactly.
you.
Yep.
Thank you.
Mm-hmm.
And when you're talking about assigning patients to locations,
Mm-hmm.
this is not telling them where they have to go. It's basically guessing that they're going to go to the nearest location and then assigning capacity based on that. Is that correct?
That is pretty close. We don't have a requirement that within the model I'm going to show right now that requires patients to go to the nearest clinic. I have a constraint that we add later that I'll show that does require that, that patients go to the nearest clinic. So that's starting to take in some of those patient preferences. For this one, while we know that, typically patients would probably go to the nearest one, there may be other reasons, their brother may live in Atlanta. And so even though that clinic is 20 minutes further away, they're going to go to that clinic anyways, because they're going to visit their brother while they're there. So that constraint isn't explicitly in this one right now, just because that kind of wasn't a hard and fast rule.
Right. Yeah. Because I'm working with the VA here in Indiana, and I've noticed that a lot of people, even though they have sort of local access, they will go to the VA hospital in Indy because I've heard a lot of reasons. One, it's like a community there, right? So they can go there and hang out with other vets. They think the care is better there, other reasons. So I was just wondering how you account for that.
Yeah, without that nearest clinic constraint, we are effectively thinking, largely most of the time they will get assigned to the nearest clinic, just because that will be cheaper as long as there's capacity to see those patients. But because of those different sort of idiosyncrasies about what patients like and what's going on at different clinic locations, we don't include it kind of in the standard model.
Yeah, because that could affect your capacity allocation if they're not going to where you think they're going, I guess.
Yeah. Renata, I think you're muted.
Sorry. We have a couple questions in the chat. Do you want to take them now, or do you want to keep going?
I can take them now. Yeah.
Okay, so Hanan has a question. He said, "Great work, Adam. It is so good to get the application latest update about your work. I have some questions for you if you don't mind. First, how do you incorporate the staff turnover rate and retirement?"
So we don't explicitly consider staff turnover within this. It would just be kind of assumed that there kind of is an ophthalmologist, an optometrist, or a technician kind of there when we need them. I'll show you some results later of kind of what does this look like if we were designing a system that didn't have any providers at it currently. So that would sort of be a way that we might consider kind of the different staffing constraints. But one thing to note, just anecdotally, the technicians in particular, kind of part of the reason that this program has been successful is because the technicians that are recruited for this are typically members of the community where that clinic is geographically. And so they are more incentivized to stay in that clinic location, that's kind of where they are, versus trying to say, we have this ophthalmologist and we're requiring you to go live in rural Georgia, which has been a challenge for the VA. So we do, there is some intrinsic accounting for staffing, just not explicitly within the model.
Okay. And then he has another question. And have you considered the role of telehealth in eye care, or more accurately, the role of technology advancements in shaping how care should be delivered?
Yes, that's a great question. And so kind of part of the reason this TECS program even exists is, it is a telehealth program in that we have technicians who are doing the screening, sending the results digitally to ophthalmologists who are reviewing them in a remote location or in not the same location. And so there is some telehealth aspect to it. We've talked with our clinical collaborators about kind of what different telehealth pieces may mean for this type of program. And what it largely could mean is just that the technician role may become more minimized, but that still, there still would be a need for at least someone to be on site. Really what it can mean is, they have the capacity to see more patients each year, which would be a great thing.
Okay. And then he has one more, and it's, it is so clear that your model is largely based on traditional care delivery, but how about hybrid care?
I don't know exactly what you're meaning by hybrid care.
If you want to unmute Hanan, because I'm not sure either.
Yeah.
Maybe yeah, I'll just, Hanan, do you want to unmute? If not, that's okay. We can move on and then maybe you can explain. Yeah, maybe I'll just tell him I'll like private message him and I'll tell him to explain. But you can go on.
Okay, I had one more quick question.
Sure thing.
Sorry for, so are you assuming that like when you station these people in like a remote location that they are going to be there like on a full schedule, like 5 days a week? Or are you looking at like partial schedules where like maybe I'm in Atlanta, but I go to like Macon. I don't know if I'm pronouncing that right. I've been there, but I don't know if that's how you pronounce it. I go to like Macon like 1 day a week and you know whatnot.
For the most part, yes, we are assuming kind of one staff member is working there full-time 5 days a week, but we can break down the model a little bit if we sort of adjust our pieces and like maybe break the like number of providers that are staffed by changing their capacity. We could say like a technician, we could have like a technician 2 that only sees 530 patients each year, and that's sort of a half-time provider. So there is a way to kind of accommodate a not full-time provider, but for this model, yes, they are all kind of a full-time position.
Thanks.
Yep. All right. I'm going to move on then to some results. So first is looking at kind of what our current state of the system is versus some of our model solutions. So first we have kind of 3 scenarios that we'll explore here. The first is running our maximized patients model with the number of providers that are staffed in each location currently and not allowing any additional providers, and saying how many patients could we screen at that level and within our budget. And then we'll run our max patients model that says, you know, keep all of our providers where they currently are, but allow for more providers to be added to the system, and then minimizing the cost to the system. So we'll run that minimized cost model with this number of 18,300 patients as the minimum number of patients we need to see each year. So first, looking at kind of our total cost, all of our models have right around the same cost, with our maximizing patients model being the most expensive at 25 million, and the current state as well as the minimizing cost model at about 24.5. What's really important to note here, and is sort of the crux of all of this work, is that our maximized patients model allocates patients to screening within the VA at a much greater proportion. So it's about 80% of patients who are in our system are screened within the VA, and that's compared to a much lower percentage in the current state, or even with our minimizing cost model. So that's really just indicating that considering community care is really important in this model, and that if we add more providers, we can, within the system, we can use them to perform screenings, and the money that we use for those providers to kind of cover the cost of those screenings is money that would have just been spent sending patients out to the community and having them incur the cost of covering that community care.
So in the min cost model, is that is the purple the community screening? Yeah. So like you're minimizing costs. So that's telling me that it's cheaper just to have them go into the community than to hire more docs to go to these remote locations. Is that how I interpret that? Because I would assume minimizing costs. If it was cheaper to have the VA serve them, then the VA would serve them if I'm minimizing costs.
Yep, exactly. So it is, you are saving about $500,000 with the minimized cost model. However, you're screening only just under 30,000 patients with that model. And with the maximized patients, you are screening 75,000. I'm
talking about just the distribution of community care versus internal screening, right? So when I'm minimizing cost, I'm using a lot of community care, right?
Yes. If our goal of if your goal is, I want to screen at least 18,300 patients, but I want to do so by potentially adding some providers, and I want to do it in the cheapest way possible, there is still a significant amount of community care within that framework.
Interesting. Okay.
But you're screening, between comparing maximizing patients model versus minimizing costs, you're screening several more patients with the maximized patients.
Yeah, assuming that you have that many patients to screen.
Yeah. And then looking at kind of our average driving distance and time as well, both of those, both the maximized patients and minimizing costs goes down quite a bit with each of those models compared to our current state. That's, of course, as we add more providers, we're going to have patients who don't need to travel quite as far. So then we'll look at kind of what happens if we start to adjust some of the inputs a little bit to see what kind of impacts they have. So first looking at what if we ran our maximized patients model and increased the budget, we can see that as we increase it in increments of $2.5 million, we see more patients overall. There's a slight decrease in the number of patients screened as we increase up to $30 million, and that's largely due to the optimality gap in our model of about 0.5%. Really, as we get up to about 27.5 million, we just sort of top out at screening just under 84,000 patients, which is nearly all of the patients that could be screened within our system. There are a handful of patients who just live so far from any possible clinic that unless we added another clinic location, we have to send them to community care. And so that's that remaining 1.9 million that we're spending on community care sort of no matter what. And with this, our average driving distance and time increases as we increase the budget. And that's largely just, as we increase the budget, we're going to see more people who lived further away. And so the average driving distance and time will increase a bit, but still under the requirements of the VA. And then looking at the minimized cost model, where we increase the minimum number of patients that we are required to screen. So we start at 18,300, which was sort of our initial case, and then increase it to 30,000 and 40,000. And we can see that we don't really increase the budget a whole lot. And that's not too surprising because we saw that we could see 75,000 patients for about $25 million. But we will start to have more costs that are allocated to our internal screening. And our average driving distance and time goes down just a little bit as we start to increase that minimum number of patients screened. And so I mentioned this briefly, but wanted to also talk about kind of what does this model look like if we started it without any of our current providers. So just kind of kept our clinic locations and said kind of starting from scratch on what providers work there. So first looking at our maximizing patients model, we can screen more patients when we don't have any of our current providers required. Keeping with our $25 million budget, we actually have just under 25 million for the amount that we're spending, and not a huge increase in the average driving distance or driving time. And we can also look at what this looks like sort of on a map. So in this first map, the smaller one on the left, we have our current state where we don't have any additional providers considered within the model. So our black dots are clinics that are VA locations that don't have any eye care currently. And then the blue, green, and orange dots or shapes are all different types of providers, with the purple stars being locations that have multiple types of providers. And then the shading around them indicates kind of where patients would be coming from to get that care. So we can see kind of going from our current state to our original maximizing patients model, where we're starting with all of those current providers. We add a lot more throughout the system, especially in this southwestern part of the state. And then when we don't have any of our current providers required, we'll add a handful more providers and start to fill in the map a little bit more, but we don't see a huge difference. So then we can also look at what it looks like when we start without our current providers, when we're minimizing costs. And here we screen about the same number of patients as we did with our current providers, but we'll save just over $1 million in doing that with about the same average driving distance and driving time. And on a map, sort of what that looks like is, again, with our current state on the left, this first larger map with minimizing costs when we start with the current providers who are required. And then in the final map here on the right, where we're minimizing costs with none of the current providers required. And interestingly, you can see here that with this version of the model, where we're minimizing the costs without any of our current providers, we only include technicians with who would perform eye screenings. Of course, we know that we still need optometrists and ophthalmologists. They would still be providing other types of eye care within the system, but as far as just the screening itself goes, we would just use the TECS program with that model. So now I'm going to go through kind of a few pieces of ways we can expand the model to improve it a little bit, but I'm not going to go into any kind of results on this, just show kind of what this would look like mathematically. So first, looking at kind of what this what we have here when we have follow-up care considered within the model. So originally we were just considering screening, but if we wanted kind of a rough way to include follow-up care as well, we could do that by solving two iterative models. The first is just the screening model where we adjust our budget with a factor of gamma that is related to the proportion of the budget that should be allocated for screening. And then we solve that screening model with that adjusted budget and and I should say this is for the maximized patients model, and set that objective value equal to n. Then we solve another model that includes both screening and treatment. Here, screening is indicated as K, that's the number of patients who are screened, plus W, which is the number of, K is the number of patients who are treated who get follow-up care, plus W times some very small value, so that as we're maximizing patients, we're seeing as many patients as possible, but also still going to try to screen as many as we can as well. We have to screen at least our big N patients that we got from the first model, and then we adjust our capacity requirements specifically for our optometrists and ophthalmologists who would be performing that follow-up care. So we can also expand the model by adding in constraints that require patients to visit the nearest clinic. So this was alluding to an earlier question. So the constraints that we would add are here, in which we have a C star, which is just the same set of clinics that we had before, but they are ordered for each zip code. So that C1 is the closest zip code, C2 is the next closest zip code, and so on. And we have it such that the number of patients within a zip code that patients have to go to get care, which is the first constraint. The second one that indicates they can only go to one clinic, and the final one that indicates that they are going to the nearest clinic. I've included the proof of this here just because it is a little bit more complicated than other pieces of the model. We're a little short on time, but I'd be happy to talk about this in the Q&A. So really,
Adam, could you just tell me what the proof is of? Like what's the theorem statement?
The theorem statement here is just that especially specifically this final constraint does actually assign patients to the nearest clinic.
Oh, okay.
Yep. So looking a bit kind of what this research looks like in practice. So first, it helps to guide VA decision making. So this is just a picture of one of the TECS sites in Blairsville, Georgia. And really our model has helped the VA start to decide where they're going to start offering eye care within as they're expanding that offering. We've also extended this model beyond Georgia and included work that models the VA clinics in Central Alabama, which is a smaller region with about 6 clinics. And then we've also spent a great deal of time creating and translating all of this model into an Excel open solver tool. This is really important because our collaborators don't necessarily have access to CPLEX. And so we want to make sure that they have a tool that they can use on the ground. So we have kind of the full model that I just shared, but incorporated into open solver so they can, as new potential clinics are added or potentially new data about where patients are living, we can update that. So all of this work is supported by the VA healthcare system, as well as the Seth Bonder Foundation and CHEPS. And I also do want to take some time to talk a bit about the research team that made this possible. So this includes my advisor, Dr. Amy Cohn, Dr. April Ma, who I mentioned earlier, who is an ophthalmologist and also works at the VA in Georgia. And then a great group of students who are all highlighted here, including some folks who worked on helping to develop and program the model, conduct literature reviews, manage a lot of our data and run Google Maps API, and then some students who also really helped with developing our open solver tool. So just briefly, I wanted to touch on kind of some of the other pieces of my research, just because we spent a lot of time on the iAccess model. So the first one I want to talk about briefly is looking at a simulation model that we have where we consider patient preferences for appointment modality. And this is with GERD patients or gastroesophageal reflux disease patients who are visiting the VA in Ann Arbor. And so with this project, we know that patients have preferences about kind of how their visit is conducted. So some patients might want to come into care. Some patients might want to use telehealth service, especially now, maybe patients don't even have as many choices. They might have to do things via telehealth. This project was conducted before COVID though. So with this, we worked with our partners in the GERD clinic to design scheduling policies that accommodate patient preferences, and then ran simulation models that demonstrate how those different policies may impact access, but also ensure that patients are still getting the appropriate clinical care. And so this is really helping us understand that, if we want to take a patient's preference for telehealth or in-person visits, what do we need to know about impacts to the patients, like how long they're waiting for patients or the number of providers we might need to hire kind of from a more system or operational view. I've also been working over the last nine-ish months with folks from the VA on how we can manage non-urgent patients who have appointments canceled due to COVID-19. And so with this, we know that we have a great reduction in capacity because of COVID-19 restrictions. And so we looked at colonoscopy and how we could consider triage strategies to ensure patients still get timely and appropriate access to the care they need, really prioritizing patients by their clinical needs. So like urgent patients really getting appointments when they need them, and perhaps other patients getting other types of care, testing at home or getting referred to come back in 6 months, things like that. And then also developed a simulation model to look at how different triage strategies impact the system, as well as patient outcomes like wait time, especially for those more urgent patients. And then the final piece of my dissertation is looking at the impact of predictive modeling on access to care. So we know there are all of these really great medical decision-making predictive models that are getting developed with a lot of the new technologies, but I'm really interested in when we start to incorporate these into making patient decisions, what does that do to access? So with this project, we're working with patients who have chronic liver disease, and some of our partners in the VA here in Ann Arbor who have new predictive models to try to catch that disease earlier when it's a little more asymptomatic. But we really want to know, how can the VA incorporate this model into its decision-making to ensure that they have the appropriate number of providers that are available and that patients aren't getting any negative outcomes kind of because of this decision-making, and kind of just generally what are the impacts on patient access and system operations. Great. So we've got, I think, 9 minutes for questions, and I'm happy to take them now.
So Anand kind of clarified what he meant by hybrid care. And he said that what I mean by hybrid care is any combination of care delivery methods, physical visits to the care facility and telehealth, or physical visit to the care delivery and physical visit to the patient household, or any other different combinations in which patients get care with and without leaving their home. And so the question was, how do you think about hybrid care as opposed to traditional care delivery?
Yeah. So yeah, kind of similar to the response about how do we incorporate telehealth. The TECS model is I would say like hybrid care light. It's not super specific. We definitely aren't going into any sort of patient homes or anything like that. One of the things we did talk to our clinical collaborators about was, what does this look like if we were to implement mobile clinics that might go from city to city performing these eye screenings, especially given the fact that it's a technician who's conducting it, and they may be able to, they can usually fit all of the equipment they need into about the size of a van. But at least within this vision, our clinical collaborator let us know that mobile clinics have been tried for a few other services in the past, and it was it didn't work out quite as well. And so they were pretty hesitant about that kind of option. I don't know I think I saw that Jordan was on Zoom, and he did a great job advocating for this and starting to develop some kind of initial models, but eventually that was something that wasn't quite as feasible. But certainly there are a lot of opportunities that we could think about other ways to make hybrid care work.
So what went wrong with the mobile care?
I don't have full details, and I don't want to speak too out of turn, but I do know it was with an auditory clinic that they were trying to do some screening for different auditory diseases and hearing tests, and that I think it just was not as well utilized as they were hoping, and so there was some hesitancy within the VA there to adopt that kind of a model for eye screenings.
Okay.
So our other question is from Anne, and she is asking, how do you think this work could be adopted by private health systems with interest in taking on rural patients?
That's a really great question, and actually kind of as I'm moving on to a faculty position, that's an area that I would really like to explore. I indicated a few pieces at the beginning, kind of why the VA is such a great system to perform this kind of work. And certainly the cost incentivization for the provider to really promote preventative care is not quite as there in private systems as it is in the VA. However, hopefully we can advocate for some policies that could help to improve that. We also know that there isn't quite the same care coordination at private organizations as there is in the VA. So that's quite a bit trickier as well. I don't have all the answers about kind of what this looks like in a private system, but I think it would be a far more complex, but also more potentially more interesting problem as well to tackle.
And then this next question is from Stuart, and he was wondering if there was any data regarding whether VA patients feel that they are getting the same quality of care via TECS as they would in a traditional setting.
Yes, there is data about that. So our collaborator, Dr. Ma, has published papers kind of first just clinically, does TECS perform the appropriate level of care as an ophthalmologist or optometrist performing an eye screening? And for that, the answer is yes, especially because there is that ophthalmologist who still has the oversight and kind of final diagnosis. So that's really helpful. And then as far as patients, there is not a lot of pushback for most of it. Most of the patients, the ones that there is more pushback from are more of the patients who kind of have been coming to get screenings regularly and want to continue seeing their optometrist or ophthalmologist. If it's a patient who really hasn't been getting screenings, there's not a lot of pushback there. Happy to get a little bit of extra care. And as I mentioned, really happy to get a pair of eyeglasses. It's a nice bonus, get to walk away with something in your hand, which is always really nice. So yeah, there is, as I mentioned, one of the limitations of the model is that we don't account for patients' preferences about their provider types. So this would not be, we definitely understand that this is a model. It is not a true state of the world.
And then our next question is from Catherine. And she said, you listed several cost factors, but she doesn't remember if you included facilities, furnishing, supply costs for additional locations.
Yes, those are included within our overall costs for implementing each type of provider. And so we have costs that are associated with hiring a new optometrist, ophthalmologist, or technician, and the equipment and facilities for that type of provider. If we already have that provider in place, then we just incur the cost associated with their salary or any other kind of ongoing annual costs.
Okay. And then this might be our last one, but from Cross is asking, from what I can recall, your model suggests that patient screening can be expanded from 29K to 75K with a marginal increase in cost. Are there any expected areas or of pushback within the VA that might prevent these gains in access?
Yeah, so I think the hardest part is that, so kind of with this model, I think this is what is being referenced. We can see that with $500,000 more, we can screen about 45,000 more patients in-house. The pushback would largely come from the fact that adding this many more providers would cost or would take a lot of time and operational burden initially. So it's just sort of overcoming, or it's not just, but it's largely overcoming that initial hurdle to just get these providers in the appropriate places. And, you know, Hanan also mentioned kind of staff turnover and how we account for that, kind of the process of hiring new providers, especially for these rural areas. Even though we have found that TECS is successful, it's still challenging.
I think there's another issue though, is that if you build it, will they come, right?
Yeah.
There's a huge, like, a lot of enrollees don't even in a given year use the services, like any services, right? So the question is, suppose I can serve 75,000 patients. Am I going to get 75,000 patients?
I'm hopeful that that number is somewhat accurate, ideally really accurate, but at least somewhat accurate, just because we used as our base patient population, patients who did use the VA for any service within that 1 year. And so these patients who are at least somewhat engaged, you know, have visited once, and especially with the technician screenings, that is affiliated with their primary care visit, which our clinician partner has really found to be helpful in getting patients kind of in the door a little bit more than you just have to come get your eyes checked.
Right. So, I mean, currently, like, people are getting their eyes checked though. How many is it? Like 18,000? Like current state? 18,000?
Yes. Yeah.
And so you're going to go from 18 to 75 just by hiring more people.
You know, that would be going directly from the current state to our maximizing patients version would not be kind of an overnight thing. That would be something that we could work towards gradually, but yes.
I think going forward, you should definitely consider the demand stream part of it. Like, as in, like, there's an endogeneity between capacity and utilization and enrollees, and also like people actually using the service or using the eye service particularly. Just my thoughts.
Definitely, thanks.
Okay, so I think that's all we have for time for questions. Thank you so much, Adam. It was very, very interesting, and I hope that you got some useful feedback. It's an amazing presentation, so I hope that you do well with your future interviews. Thank you guys so much for asking questions. I'm going to just end the meeting just so that we're mindful of people's times, but thank you so much.
Great. Thanks very much.
Thanks. Bye, everyone.